Hey everybody, Dennis here with Respiratory Sensei. Hey, I'm super excited about the video you're about to watch. They're part of a new series and they're really kind of special. And that's because they cover specific procedures in the official sense. In other words, that the procedures as set forth by the Clinical Practice Guidelines as set forth and maintained by the American Association of Respiratory Care. Be sure to subscribe and hit the notify button so you can see all of them. And these procedures are procedures that you'll want to follow when you take care of patients, but they're also very helpful in preparing you for the NBRC credentialing examinations for respiratory care. So with this video and others just like it, enjoy. The use of incentive spirometry is primarily used to prevent postoperative complications such as pneumonia, atelectasis, and postoperative infection. Essentially, the maneuver is a deep breathing maneuver, and it turns out that when we take deep breaths and we get air all the way to the distal portions of our lungs, including the alveoli, then it becomes very difficult for secretions to consolidate in that area and cause pneumonia and colonize and possibly cause a bacterial infection. Essentially, the maneuver is to simply get the patient to take a deep breath with a device such as this one. In addition to reducing the chance of postoperative infections and pneumonia and other complications in ventilations, taking a deep breath and the maneuver associated with incentive spirometry has the ability to pop open alveoli, which means we can reverse something called atelectasis. And this can go a long way in preventing other postoperative complications. It also increases ventilation and ultimately improves gas exchange. As we'll explain in more detail a little later, incentive spirometry involves taking a deep breath after relaxing out and exhaling a tidal volume. Now this part's important because this is the most commonly misunderstood thing about incentive spirometry. It is a maneuver that happens after we just relax and passively let out our tidal volume. Very often, patients might confuse that with blowing all their air out and then taking a deep breath in. If they were to blow all of their air out forcefully and then take a deep breath in, this would be called vital capacity. But an incentive spirometer is associated with measuring inspiratory capacity. And so one of the key things that we'll coach patients later on is that as they relax their tidal volume out, don't blow all their air out, but just relax their tidal volume out and then take a deep breath in as far as they can and for as long as they can. And this is called inspiratory capacity. This type of inspiratory maneuver is something that happens naturally in the body, and we know of it as a sigh. That happens to all of us. We might be sitting at our desk studying, and every once in a while we just kind of go, that's a sigh. And in a way, that's mimicking what we're doing with incentive spirometry, except that with incentive spirometry, we're doing it a little bit more deliberately, and we're coaching the patient to take it much, much farther and breathe in as far as they can. But the physiological outcome of the body of a sigh is very much the same thing. And that sigh might also be associated with yawning. Now, do not confuse this. Somebody can yawn without taking a deep sigh, but mostly they can't or don't. In other words, if you're yawning, which we often do in the morning and before we go to bed because we're sleepy, what we're really doing is opening up the vessels here, the large vessels, and getting more blood to the brain. So the reason why we might yawn is to get oxygen to the brain, but it is also often associated with a very deep breath, which is a sigh, which helps improve gas exchange at the alveolar level. It's worth noting here that PEP therapy, or positive expiratory pressure therapy, also called vibratory PEP and other names for the very similar type of therapy, are not a good substitute for incentive spirometry. And that's because they don't usually consist of an inhaled volume. And so in that sense, incentive spirometry is in a unique position to help the patient improve a gas exchange and generally improve ventilation. Just remember that this device and the therapy that goes with it has the ability to prevent atelectasis, reverse atelectasis, and generally improve a gas exchange between the alveoli and the pulmonary vasculature. In other words, it just gets more oxygen in the blood and, of course, more CO2 out of the blood. And, of course, that's a good thing. Well, now let's talk about the procedure. The first thing that the patient needs to do as you hold this up to the patient is that before they put this in their mouth, they need to relax their tidal volume out completely. Just relax. Remember, they're not going to blow out all of their breath forcefully. That's not what we're doing. We're doing inspiratory capacity, which starts at a relaxed tidal volume out. Once they've done that, then they'll take the mouthpiece and they'll stick it in their mouth. What's important there is that they go past their lips and really past their teeth as well. Once that happens, then they begin to take a deep breath in. What's important now is that you'll see that the puck will begin to rise here, indicating volume, but there's another indicator over here that indicates flow. If they breathe in too fast, then air has a tendency to not penetrate the deepest part of the lungs, and if it's too fast, this little yellow puck will rise up into the fast zone or go up into this area here. You'll see closely that what we want them to do is just barely make the yellow flow indicator rise just a little bit. And then, of course, as it does, then that's the appropriate flow. And then, of course, they breathe in as deeply as possible, and they get the puck to go as high as they can. Technically, the maneuver could be over at that point, but just a little bit of practical advice as well. That when they get to the very top, if we're coaching them, if we can coach them to just take that extra little effort, pop that puck up just a little bit more, then what happens is that we have a tendency to pop open alveoli at that very point. And so that increases the ability for the therapy to help them. Now, once they get to that point, then they will remove the device from their mouth and then they will exhale. This is somewhat important. What we don't want is for them to exhale or to blow out into the device. And that's because our exhalated breath has a lot of humidity in it. That moisture can accumulate in the device. If moisture accumulates in the device, then it can have a tendency to colonize bacteria and other pathogenic organisms that may not be desirable for us to re-inhale later. In fact, for sure, they are not desirable. Now, that doesn't mean that if a patient accidentally exhales into the device that you need to throw the whole device away. You can still use the device, but generally we try to keep the patient from exhaling into the device. Now, once they do the maneuver once, and they can repeat the maneuver once, twice, 3 times, always trying to beat what they just did. We might also have them relax and take just a little bit of break between each attempt. We can attempt up to about 10 times, and really that's the procedure of incentive spirometry. Now we need to talk about how to make sure our use of incentive spirometry is effective. And to be effective, we have to consider 3 important aspects. One is patient selection, another one is instruction, and of course another one is supervision. When it comes to selecting a patient, we need to be able to select a patient who's capable of doing it physically, but they also need to be able to do it in terms of their comprehension. And so for patients who have poor cognitive development, or they can't understand what you're doing, or maybe there's even a language barrier and you can't get a translator, that would be a poor patient to engage in training and to use incentive spirometry. So that would certainly affect the effectiveness of the therapy. The other thing that we need to think about is instruction. This is perhaps the most important part. It may seem easy enough as you look at this, what looks like a toy, a device that you just stick in your mouth and take a deep breath, and the puck goes up, and of course it'll work if somebody does that. They don't seem to need a lot of instruction, but as we look closer, we need to be able to guide the patient in the flow rate and coach them into setting a goal and to being able to take a deep breath in, teach them how to not exhale into the device. There's a number of things that we can instruct that will drastically improve the effectiveness of the therapy. You know, there are a number of things that go wrong as we provide instruction, and so gradually people might devolve and not remember what you instructed them in the first place. And so for that, we have to involve the 3rd element of being effective, and that is supervision. Now, it doesn't mean that a nurse or a respiratory therapist has to be present every time the patient needs to do the therapy. In fact, we want them to do it in between the times that we see them. We want them to do it frequently and quite a bit, so without our presence. However, if we let them go for an hour, 8 hours, a day, 2 days, what you'll commonly find when you come back is that they have somehow devolved, or they have changed the maneuver to something that's much, much less effective. Just to give you an idea, the most common thing that they might change, and this is really very common, is that instead of relaxing and taking a deep breath in and then taking the mouthpiece out and relaxing and blowing their air out, they'll have a tendency to start blowing their out before they take a deep breath in. And there's a good reason for that. Remember, they're having fun with this game by trying to get the puck up to the top. But watch what happens when I do it normally. I just relax my tidal volume out, and then I'll take a deep breath. Okay, I got to 2,000 on there, but let's say I'm a very motivated patient and I'd certainly like to see that go higher. I could accidentally figure this out. Well, gee, if I blow all my breath out first, I might be able to get that number up a little higher. And watch what happens when I do that. Now I got to 3,000. Now if I'm a patient, I think I'm just doing great because I just got that thing to 3,000. But this is what happens when you leave patients alone unsupervised. They might suddenly decide, hey, it works better if I blow my air out first. The problem is if they precede the therapy by blowing all their air out first, then they can have a tendency to cause atelectasis, which is exactly opposite of what we're trying to accomplish. So the most common thing that you'll have to do to recoach patient is to not forcefully exhale before they start the maneuver. Another little quick tip is that for some reason in the field that if they don't involve respiratory therapists in the first place, you might walk into a patient's room and you're there to see the other patient, but you notice the patient in the bed that is not even your patient. You don't even have an order to go see them. They might have an incentive spirometer at their bedside. It's very appropriate, even though that's not your patient, to just say, hey, Mr. Johnson, I notice you have a little incentive spirometer. Can I see how you're doing? And so remember, as respiratory therapists and as all healthcare workers are supposed to do, we should be coaching all patients at all times on how to do this maneuver. Very commonly, you'll find that it's just been sitting at bedside and it's been neglected because somebody's not supervising or they've forgot to coach the patient or even teach the patient on how to do it in the first place. So just because it's not your patient doesn't mean you don't do anything. You can help all patients if you just see this at the bedside. This thing is a sign that you as a respiratory therapist or even a nurse need to engage in instruction. Now, as we'll talk about in just a minute, it is contraindicated to use this if there is zero supervision. As I said earlier, you don't need to hover over them and see it done every single time in the presence of a nurse or a respiratory therapist. But if you're just going to give this to the patient and never supervise them, then technically it's contraindicated because the patient could start using it in an inappropriate way, and that could cause atelectasis if, for instance, they were to exhale every time they used it. So no supervision means this thing is technically contraindicated. Other contraindications are all centered around the ability for the patient to do it. So if a patient is comatose and can't follow instructions, then certainly you're not going to do it there. If it's a very small child and they're incapable of understanding the instruction and there's no supervision, then it would also be contraindicated. Another reason to be contraindicated is if the patient has some sort of paralysis. A good example of that would be neurological interventions such as myasthenia gravis or Guillain-Barré, where their diaphragm is paralyzed in the first place. So you wouldn't want to take this to a myasthenia gravis patient and give them an incentive spirometer. By the way, what I'm saying would be certainly fair game, a fair game question for the credentialing examinations for respiratory therapists. So I'd watch that closely. If you have myasthenia gravis or Guillain-Barré or a small child who can't understand or somebody who's comatose or somebody who has shown that they have a severe deficit in their ability to understand or a cognitive deficit, these things would be contraindicated and you really wouldn't suggest their use. One other nerdy contraindication to incentive spirometry is if the patient is unable to produce 10 milliliters per kilogram in volume, or they're not able to achieve an instrument capacity of at least 33% of predicted. In that case, then incentive spirometry is not the therapy that we want to use. The therapy that we would want to use would probably involve some sort of machine to help us mechanically push in a deeper breath so that they can get sufficient inflation of their alveoli and their lungs in general. And by the way, some surgical procedures might make incentive spirometer contraindicated. And that seems to fly in the face of what we learned because the key indications is that they've had surgery, and this is the number one way to prevent postoperative complications. But keep in mind that some surgeries might involve incisions or incision sites that if the patient were to take a deep breath in, it would stretch the stitches or possibly cause a problem in the incision site itself. Also, remember that incentive spirometry causes coughing, which we like coughing as respiratory therapists, but that coughing could also cause, the explosive nature of it could cause a bursting of stitches or an incision site. So we do have to be careful after surgery to see, is it really appropriate to use incentive spirometry at this stage of the patient's healing? Now, beside contraindications, we also have what are the good effects to use an incentive spirometer? What can we get out of it? What are the good outcomes? So one is that they have a tendency to decrease their respiratory rate. That's because as we take a deep breath in and we increase the size of the tidal volume and the gas exchange that goes through the alveoli and the oxygen molecules that go into the blood, then the brain will trigger less of a need to ventilate or to breathe in and out. So if somebody has a higher respiratory rate, then one of the good outcomes is that it will decrease the respiratory rate. It also has the ability to decrease their temperature, or in other words, help avoid a fever, which is really just a way of saying help them avoid an infection. You'll also achieve better vital signs in general and better breath sounds. You should be able to hear aeration in the deepest part of the lungs. The bass is better because we're getting air into those spaces and we're resolving or at least preventing atelectasis, which allows better ventilation in the distal aspects of the lungs. Additionally, the chest x-ray is going to look better. It's going to show there's better aeration, and so that's also another great outcome of incentive spirometry. And finally, as you might imagine, you should achieve better oxygenation in the blood. In other words, your PaO2 as well as your PCO2 should look better. As you achieve better oxygenation in the blood because you're ventilating better, you also have the advantage of being able to use less supplemental oxygen, or in other words, to keep use of lower FiO2s. Now, it's also important to remember that incentive spirometry is a therapy, and as a therapy, it has to be documented. The question is, what do you document regarding this therapy? Well, I want to tell you, and by the way, this would be certainly fair game on any credentialing examinations for respiratory therapy, especially, but probably for nursing as well. So the key thing is that you're going to want to document, first of all, the date and time. Okay, that's a little bit obvious. But you're also going to want to document the volume achieved. What's important here is that they may say document the inspiratory volume, but it would also be fair to talk about it in terms of documenting the inspiratory capacity, because that's the name of the volume when we do the maneuver correctly. That's what it's called. The other thing that you could document, of course, is the repetitions. It's not necessarily important. In fact, you would avoid documenting the time that you spent on the therapy, but would be appropriate to document the fact that you had the patient take this breath in maybe 10 times. By the way, 10 times is an appropriate amount of times. For some patients, they may be sedated, they may be tired, they may not be able to only do it 5 times, and so you would document that. You could also document any cough that came out of it, and you could also document any difficulties in understanding or cognition during the procedure. So those are the careful things that you'll want to document when doing the incentive spirometry therapy. Now, let's take a look at the devices. Generally, when you're talking about incentive spirometers, there are 2 types of devices. And one is, that we've talked about before, is volume-oriented, and another one is flow-oriented. The flow-oriented ones look like this. They have these balls that you're supposed to elevate. They're different colors. They're actually different weights. And then you're trying to get the patient to maintain a specific flow rate as the patient breathes in. The other type does not have balls, but it has something called a puck. And as the puck goes up, it indicates a volume that the patient is achieving. Here's what you really need to know about this. The kind with the balls, or the flow type devices, are not as good. They increase the work of breathing. While we know that using incentive spirometer will require work and effort from the patient, it's not our job or our desire to increase the work of breathing in the patient. That's an undesirable characteristic. And so because of that, we find that patients are able to use the volume type easier. It has a decreased work of breathing, and therefore, and especially on any credentialing examinations, you'll always want to say that the volume-oriented spirometer is the better device. So always pick it first. Now, let's take a closer look at this device, this volume-oriented incentive spirometer. Okay, so here we have our incentive spirometer, and this is a volume type spirometer. Now, first thing I'm going to do is just note that there is a removable corrugated tubing with a mouthpiece, and just so we can take a closer look, I'm going to set that aside. So what we have first of all here is that because this is a volume type of incentive spirometry, it's definitely got the volumes here. Keep in mind that's in milliliters, and so if you're documenting, you're probably going to be documenting what the patient achieved in milliliters. And so did they get 2,000, 3,000 milliliters? But also keep in mind that you could document in liters, but 3,000 milliliters, for instance, would be 3 liters. And so you have to be sensitive of the unit of measure. Then also what you'll see is that over in this area, and I'll get kind of close here, this is the flow indicator. And what you'll see is that the best flow is just barely up above the little baseline here. What that means is that the patient, the slower they breathe in, the better it is. And so there's a rating of best, better, and good. But if they were to go up into this zone, and believe me, it's easy for patients to do that, then that's too fast. And that would be a reason to coach the patient to take their breath in just a little bit slower. There's another part of this, and that is this changeable indicator here. This is what could be used to set a goal. It could also be used to set for the patient as they remember what they were achieved last time. So if they're at home, you might tell them to just set this to whatever their highest point is. That way, when they come next to it, they know that they're trying to get a volume that is higher than this yellow mark. But after surgery, a good idea would be that if before surgery they got to about 3,000, then you could set this to about 1,500 or so, or about half of the preoperative accomplishment. That would be their initial goal. Remember also that whatever you set this as a goal, if the patient's able to do it and it comes up only to here, it's not very close to that yellow mark at all, you're going to want to lower the yellow mark not to where they achieved it, but to just slightly above where they achieved it so they have something to shoot for. Remember also that when they hit the yellow mark, when they're able to get at that, then you should coach them to raise that yellow mark just a little bit more. But it's a very simple device. This is a volume-oriented incentive spirometer. It is the most common type of incentive spirometer used, and it is the preferred one because it imposes less work of breathing. Basically, it's just easier for the patient. All right, here's the key takeaways with incentive spirometry. This is also true for any of the credentialing exams that you might have to take as a respiratory therapist, and that is that an incentive spirometer is the #1 most effective way of preventing post-operative complications. The key to being effective relates to supervision and instruction, and a person may set a goal with this. So the key indicators are that the patient is going to have abdominal or thoracic surgery, but what's a good point to remember here is that you're going to want to use incentive spirometry before surgery. You can do that so that you can get a baseline value of what's the maximum they can achieve. In other words, you're going to record their inspiratory capacity. As you do record their inspiratory capacity, you can come after surgery. The best initial goal is to be 1/2 of their preoperative accomplishment. So if they were to get 1,600 before surgery, then the good initial goal after surgery would be about 800. Now, be careful. Don't marry that significantly. If their initial goal is 800, but Mrs. Johnson's only able to get 200, then what you're going to want to do is take this little goal indicator and lower it down closer to 200. Not at 200. If she can do it, then maybe you put it at 300. But you want the goal to be just higher than they can accomplish. Now, that's because we're trying to incentivize them. If I said, Ms. Johnson, I see that you got way up here afterwards. You're only doing 200, but you need to get to 1,600. So I know you can do it. Just keep doing it. That's not as incentivizing as if you set it at 300 and say, Ms. Johnson, you're doing great. You did 200. Let's see if you can get to 300 by the next hour. And then you keep raising that goal. And that's an important aspect of incentive spirometry, that it has to be goal-oriented and that you can keep raising that goal with the patient. Finally, remember that a volume type or a volume-oriented incentive spirometer is far better and far more effective than a flow type incentive spirometry. And that is the incentive spirometry procedure.